Well, good afternoon, everyone. My name's Roy Lilly, and welcome to our lunchtime seminar on wound care. And thank you to our sponsors. Thank you to our sponsors, Fala, for making it possible. We have a fabulous lineup of speakers, and we'll be very pleased to answer your questions. You can see on the screen there's a chat box. Drop your questions in there. Please don't go home thinking, do you know what? I wish I'd asked that question and I didn't. And I know you're home anyway, but you know what I mean. Don't waste the opportunity. We've got some real experts here that can answer your questions. Now, wound care services are a huge issue on a global scale. I just found that the total wound care market is worth nearly 30 billion US dollars. And that was and by 2027, it's going to be God knows how much more. And the NHS spends 5% of its budget on wound care. That's about 5.3 billion pounds in that case. And at least 22 million wounds are treated in the UK on an annual basis. And at least 200,000 patients have a chronic wound. I mean, this is a colossal part of global budgets and a colossal part of NHS budgets as well. And of course, most of this puts a huge pressure on district nursing. And we all know, of course, the district nursing numbers are getting smaller rather than they are getting bigger. Just to give you a comparator, the size of the issue wound care is for the NHS is comparable to the size of the difficulties we face through obesity. So it's a huge problem. Part of solving that problem, of course, is in the efficiency of how we look after people with wounds. I mean, it will be good if we could stop them getting them in the first place, and perhaps we'll hear a bit about that as well. And of course, the right choice of product is a very important part of how the patient recovers. So let's hear then from our keynote speaker. We're very lucky to have with us today Dr. Leanne Aitken. She's lecturer and practitioner at the University of Huddersfield, and it's my great pleasure to introduce her. So, Leanne, over to you.
Thank you so much for that introduction. And so hopefully you'll be able to see my slides. So I was asked to do this presentation really thinking about where we are in wound care across the UK. And I've just got one simple question for the audience. Is it time to change the dressing, or is it time to change the culture in terms of how we deal and treat patients with wounds? As Roy's already said, actually, if you start to look at the global market of wounds, there's only one word to call it, and you would have to say that we've got a global crisis. And we've got a global crisis because of the perfect storm. We have a growing number in terms of patient population. We have an increased amount of patients that are over the age of 65. This is a multi-billion-pound industry across the whole of the globe. And it really impacts on many parts of our healthcare system, because 66% of community nurses' time is devoted to wound care, and around half of every hospital bed is occupied with a patient with a wound. And not only that, many patients with wounds end up having a prescription of antibiotics. Around 16% of all prescriptions for antibiotics is to do with wound care. And we all know the threat in terms of antimicrobial resistance. We've just been through COVID, where we had no known cure. Imagine if we do get true antimicrobial resistance, so we're not able to fight any form of infection, then the globe will really be in crisis. Just to bring those figures back to the UK, I think that what we've shown, or what Julian Guest shows with these fantastic publications, is actually the burden is increasing year on year. So we've gone from spending 5.3 billion in 2012 and treating 2.2 million patients to actually now it's costing us 8.3 billion and we're managing 3.8 million patients. So the growth of the number of patients that we're treating is increasing year on year, and we certainly haven't seen that amount of rise in terms of staffing to be able to cope with that demand of patients. But actually, do we need more staff? Because actually what you can find from the data is that we have variations of clinical practice, and we have lack of standardization of evidence-based care. So for a venous leg ulcer, the evidence is strong compression. But as you can see from this slide on the left, this graph on the left, that not many people receive that high level of compression that's required. Many people don't receive any compression or subtherapeutic compression. This is a lack of standardization. It's an absence of evidence-based care. It's the same with patients who are presenting with a pressure ulcer. Many of these patients are not on the appropriate redistributing surface. So actually, is it the lack of standardization that's caused this global impact? And why is that? So I just want you to reflect back really and ask yourself a question. Over the last 2 decades, how much progress do you think has been made in the management of pressure ulcers, lower leg ulcerations, or surgical site infections? And actually, when I ask that question and I think about it myself, I think the answer is very little progress. We have a few more products, but we still are treating patients in a very similar way as what we did 2 decades ago. But if I ask you that same question as how much has your mobile phone changed over the last 2 decades, the answer would be it's unrecognisable to what it used to be. So why is that? Why is some form of the technology in the world improving and some things has been very little progress? And just to come down and look at those 3 different arms. In terms of lower limb care, we have huge problems. We have no national prevalence data. We're unable to say how many patients are suffering from a lower limb wound within the UK. I find that abhorrent. We have no monitoring of the time to assessment. We have no option of providing national benchmarking. We also have problems within our clinical workforce of do they truly have the capability to assess and diagnose these patients correctly? And the data has to say, no, we don't. We have an underuse of ineffective therapies such as light compression, reduced compression, and we have an underuse of evidence-based practice, strong compression, venous intervention. And the same can be said about surgical site infections. Have we really made much difference since 2015 to 2019? The number of surgical site infections in Scotland for hip surgery has remained stable in all of that time. We've shown no improvements. Despite all of the safety bundles, despite all of the focus on that perioperative journey, we haven't reduced the surgical site infection risk at all. And it's not just in hips. You can look at many data from vascular surgery that says that the data is all over the place. There is no sustained improvement in any of these fields. And why is that? Well, you have to come back to, we have no national prevalence data. We have no robust reporting mechanisms. This inability to benchmark, does it lead to an inability to progress our thinking? It does rather annoy me that the surgical site guidelines that we should be adhering from NICE says that we should cover a patient post-operatively with an interactive dressing. But actually we'll all recognise that 99% of patients come out of theatre with a gauze and pad type dressing. That is not an interactive dressing. So even when we've got the evidence and the recommendation, we still don't standardise to that approach. I think the best in terms of change that's happened is actually the management of patients with pressure ulceration. I think you can only just congratulate the Stop the Pressure, the React to Red campaign for the difference that they made. And they certainly did have good outcome data to say that they were showing a reduction in pressure ulcer prevention. That is until COVID hit. And when COVID hit, unfortunately, the severity and the prevalence of pressure ulceration has started to peak once again. So we haven't got this sustained improvement in any of the fields over the last 20 years. And why is that? Because wound dressings have evolved in that time, there has been research the manufacturers has helped to change from that passive wave of dressings where we simply used gauze or sponge-based dressings to dressings that help to change the environment of the wound, help to reduce the amount of MMPs, help to control the exudate, providing that moist wound environment. And even from then, we've got further interaction in terms of truly activated wound dressings, ones that have got growth factors embedded within them. They've got tissue engineering, proper scaffolds that were able to change the condition of that wound bed. So the science of the wound dressings have evolved, but actually have we? Because how many patients can access that active healing phase of interaction? Majority of the patients that we still treat today, we're only trying to change the environment of the wound and manage their condition. And if you look at the wider pieces of literature, it's so shocking to see that back in 1985, there was a paper talking about the extent and the problem of the care of the patients with a leg ulcer. That document, that publication was practically repeated nearly 30 years, no, maybe 40 years on, when we identified that we still have the same issues with the service provision for these patients with lower leg wounds. And I find that that change is just insane, that we haven't moved on in our thinking, the culture, the provision of these patients in the last 40 years. We talk a lot in the NHS about having a person-centred care, person-centred approach. And what does that truly mean? Well, it means actually being kind, respecting that people are different, thinking about each individual as unique, putting their needs first in front of the organisational needs, working with the person rather than doing to the person, and making sure that we see the whole of the patient, not simply the condition. But how successful do you think we are at doing this? How many times have you just delivered a transactional dressing change? You run into that patient, you change the dressing, you run back out again. Is that truly person-centred care? I was the proud chair of the Legs Matters campaign for around 3 years. And I just want to share with you some of the words of the patients that we gained. They said that the system is failing them, that the pain is taking over the life. They keep asking for help and not getting it. I was told all of this is due to do with my weight. How come I haven't seen anybody sooner? I've seen my doctor 2 or 3 times and they don't seem to care. That is the true assessment of the patients and their feedback at this moment in time. And I must say that we should be ashamed of these words. And that's why the Legs Matter campaign have published this document. We'll provide you a link. It's free to download, because actually we want to make a case for systematic change and transformation. Because unfortunately at this moment in time across the UK, you could say we have a bit of a toxic culture within wound care. We have gone down to task orientation. We're trying to do our best, but at the same time, it often is not what the patient wants, deserves, or respects. And I say this toxic culture, and this may be very dramatical words, but I just want you to reflect on some of these signs of that toxic positivity that we do. How many of you as nurses has hidden your painful emotions? How many times do you ignore the problem? How many times do you try to dismiss people's feelings? My wound dressing was wet today. Oh, well, sweetie, we'll put you a new one on. That's a dismissal of that patient's service, of that need. How many times do you go home feeling guilty, sad, or angry for the level of care that you provided? This is all forms the part of that toxic positive culture that we seem to be embedded with. So I want to really ask you, how can we change that? How can we influence that? How can we make a difference in our thinking? And I think it has to start with the simple words we use. If I ask you out there, what do you think about wound management? Many of you will say you need to assess the underlying cause, do good wound bed preparation, control the patient's pain. We need to manage that wound well. But I have to ask you, why are we managing wounds? Why are we not healing wounds? Surely our language should be about wound healing, not wound management. And I blame some of this on us as the clinical academics, because actually sometimes we've made wound healing far too complex than it needed to be. We need to simplify this. It is not witchcraft. It is relatively easy to do with a baseline level of education. And I do think that the wound products that we use currently doesn't help that simplification. The words, the hydrofibers, the hydrocolloids, what does that truly mean to the average nurse? And actually, if we can get products that have got a clear aim, clear goal, and clear messaging on their packaging, surely that helps to simplify wound care. So there's many things that need to change. We actually need the service to start to actually be more proactive and stop firefighting. We need to stop being protective as our service and actually calling out where we are and asking for help. But we need you as an individual to really look at, how do we share good practice? How do we share those success stories? How do we ensure we've got good leadership? But most important, we need to ensure that we've got the right data. Within the NHS, we collect a whole host of data. But do you know what? We can hardly pull out any information from it at this moment in time. The National Wound Care Strategy Programme is going to help us with that. So we're going to be able to get some true information about where we are. That will help us to benchmark our services, understand where we need to improve, and embed that continual quality improvement methodology that we need. So I ask you really, I'd like you all on this call to start today. I'd like you to change the language that you use. I'd like you to start thinking that wound care is easy. I'd like you really not to use words like advanced wound products unless they truly are advanced. A foam dressing is not an advanced wound product. It was created in the 1980s. Nothing from the 1980s is still advanced. I'd like you to really think about, stop using the word wound management. We should be healing these wounds, closing these wounds. And the language is so important when we think about the culture. We need to think that non-healing is not normal. We shouldn't accept that. We should be escalating that patient, inquiring why their wound isn't healing, allowing them access to the most advanced technologies of wound products as soon as possible. So I ask you just to reflect on what's your part in all of this. Because I say that as a collective, we need to stop the complicit failure. We need to be the change you want to see, and you have a role to play in that. Thank you for listening. I'm sure this presentation has raised some heckles or even some questions. Please put them in the Q&A box, and I'd be delighted to be challenged on anything that you've heard at the end of all the presentations. Thank you for listening.
Leanne, thank you very much. You're right, that was challenging, but the situation looks to me like it needs to be challenged. We've got time for questions in the end, but I just want to ask you, Patricia Holman has popped a question in, which seems to me a really sensible question. And Patricia, thank you very much for your question. She said, as registered nurses, no matter what area we work or specialize in, we all come across wounds. Why is prevention and treatment, of wounds a higher priority during the initial nurse? Why isn't prevention? I think she means why isn't prevention and treatment of wounds a higher priority during the initial nurse training? Would this help, do you think? And it does seem to me we're kind of running up the down escalator here. The focus, I mean, you absolutely put a focus on treatment and the decisions that we make about treatment, but surely that's kind of firefighting. We need to do some root cause analysis.
I completely agree, Roy, with that. And you know, there needs to be lifelong career education in wound care for every single nurse that's out there. And yes, absolutely agree that that should start at your foundation level of your registration. But I'd be saying at the same time, we need that for our apprentice nurses, for our healthcare support nurses. We need access to that level of education. In terms of the direct question for the registered nurses curriculum, the problem is the curriculum is a quite political hot potato, and everybody wants a part of that. And actually, on average, the wound care undergraduate nurses get 6 hours training per year on wound care and pressure ulcer care, which is just ridiculous.
When you think it's 5% of the NHS budget, it's more than ridiculous. It's just damn stupid. Look, I could chat you about this all day, but we're going to move on because we've got our next speaker now, Katie Leake. She's the lead tissue viability and lead on tissue viability and continence at the University Hospital of the North Midlands. So, Katie, over to you. We've lost your sound, Katie. If you just click on the little blue microphone at the top of your screen, we can all hear you. No, we still can't hear you. There's a little microphone in a little blue box at the top of your screen. Can you click on that for me and we should be able to hear you? No, we still can't hear you. Okay, well, look, what I'm going to do while you sort that out, whatever that technical thing is, I'm going to move on then and take the speakers perhaps slightly out of order because we must finish at 2:00. So I'm going to move on to Sian Fumarola. She's the head of clinical procurement and integrated supplies at the procurement department at Stoke-on-Trent of the NHS supply chain. And I'm just wondering whether your title is as long as the supply chain, Sian. But anyway, over to you.
Hi, can you hear me?
We can hear you, but we can't see you.
Oh, okay. Well, we're
so if you
halfway
just
there.
click on the little camera, the blue box at the top of your screen,
Yeah,
we should be able to see you.
Mm.
Yes, we can see you now. Far away.
Can you? Oh, okay.
We can see you and hear you. So over to you
Okay.
while
Thank you.
Somebody in the background, Jenny, will sort out Katie. Right, off you go.
Thank you. I can't see my slides.
Okay. Jenny's in the background. Jenny will put up your slides for you. This is going so well, isn't it? Here we are. There's your slide. Well. Appropriate decisions. We've got them. Off you go.
Thank you. Okay. I do have to apologise in advance. One or two of my slides haven't transferred very well, and some of the data is missing. So I'm going to have to ad lib for those slides. But I have got my presentation open alongside me, so hopefully I can see those. So yes, my name's Sian. I am a nurse by background, and I've worked as a nurse for nearly 40 years now. For 20-something odd years, I worked as a clinical specialist in wound and continence care, and then that led me into working with NHS supply chain and the Department of Health, looking at particularly clinical specifications for wound care products. So talking to clinicians nationally to understand what good looked like, what best practice looked like, how they made their decisions about wound care product lines and so on. And I am now in the role of head of clinical procurement, looking after 5 NHS organisations and helping the wound care teams to come to decisions about wound care formularies and services and so on. So I'd just like to talk to you a little bit about how we make those decisions and perhaps give you some insight into some of the things that maybe we should be looking at. Had we have had Katie's presentation first, it perhaps would have, this would have perhaps led on a little bit better, but not to worry. So unwarranted variations in wound care, this is not new. I know in Leanne's presentation, she discussed unwarranted variations and actually how that led to prolonged chronicity of wounds, in that maybe we're not looking at the right things. Maybe we're not looking at a proper treatment pathway. Maybe we're not looking at underlying conditions. Maybe we're focusing too much on the product that we're actually applying to the patient. And as she commented about advanced wound care products and foam dressings and so on that have been in the market for a very long time, and actually how maybe they're not particularly helping wounds to heal, and we should be looking at other things and focus on other areas, as highlighted by the National Wound Care Strategy Programme very well. So in this piece of work that I'm sharing with you here by Gray and colleagues, they raise concerns about bandages types and continually switching, successive wound dressing changes, indicating confusions about wound care knowledge, you know, and maybe not the expertise in managing, but actually confusion around the types of products that we were using. I know when I was managing the service in an acute hospital, we would regularly come across patients who'd been managed for months and in some cases years, and never really found themselves into the correct services with the correct specialists and professionals to look at their underlying diagnosis for a wound, because the nurses had actually thought that it best to keep changing the type of dressing that they were using, so swapping from one foam dressing to another, to a hydrocolloid, to a gelling fibre, to something else, because they felt that until they'd actually exhausted that supply, that they shouldn't really be referring the patient on to a specialist to review, that they should look at all those options. And actually it really does delay specialist referral and appropriate treatment. And if we think about performance indicating factors, and I know Katie's going to talk more about this in her presentation, about actually what goes on at ground level. So how do we actually how do we work? How do we choose products? How do we work our way through processes? And is it any wonder that all this confusion exists? You know, in any one area, you might have a choice of several different types of products, and performance indicating factors are characterised by the job, the individual, the organisation, and influencing human performance. So job factors, you know, and we're all subjected to this, aren't we? You know, the clarity of signals and instructions, labels in clinical areas, alarms, the complexity of the task that we're performing, because we're probably not performing one task, we're multitasking all the time. The divided attention, constantly somebody wants to speak to you. The patient next door requires attention. Somebody's on the phone. The doctor's just arrived on the ward, you know, and in the patient's home, you know, the dog's barking, somebody again is knocking on the door. So the preparation of the task, it can be quite complex, can't it? Particularly if you're working in an area that you're not used to. And I'm thinking really about our transient workforce, particularly, you know, during and after our pandemic, where lots of people were working outside of their usual areas, and we had lots of bank and agency staff covering for staff who were off sick with COVID and so on, and we were all displaced and we didn't know where anything was, and it makes the task so much more complicated. The time available to work, the light we're working in, capability fatigue, stress, you know, that work overload. So is it any wonder that when we are faced with these quite complex decisions about products, and we've got a whole array there, that actually we might be making the wrong decision? So is it any wonder that, you know, because we've got too much choice, that maybe that actually adds to our confusion? I mean, our colleague Jackie Fletcher back in 2015 was already raising concerns then, and there was lots of wider discussion amongst the tissue viability communities about have we reached that point of oversaturation in wound care dressings and choice, you know? And she highlighted some research by Price and colleagues from way back in 2008, and we can all say this still happens. And they suggested that clinicians err on the side of caution and make some quite poor treatment choices based on the wound care dressings that they choose. And they identified some patients had up to 7 different dressings in use at any one time. And we've all been faced with these scenarios. And you know, we've even got a term for it in England called the sandwich, where we sandwich various types of products together because we clearly have little understanding of their clinical specification. And where do we find the information about wound care products? Well, I don't know. I see we have got a bit of a global audience with us today. So, you know, and in the UK, we've got the Wound Care Handbook. This is 370 odd pages of some data. It's not technical data, but it's a brief description of the type of product. And in that book, there are 112 iterations of foam dressings. Many organisations will have access to 3 or 4 foam dressings, you know, and in the British National Formulary as well. There's very limited information in there, but they are listed. But there are hundreds and hundreds and hundreds of different types of wound care products. So it's no wonder that we're so confused. If you're lucky, you'll have, you know, a local or a regional wound care product formulary. But should we be asking our questions about who's making the decisions about the products that are included there? What kind of technical data do we look at when we're choosing those products? Are they the right products for our patient group? Because patient groups are different. I spent lots of time in a previous role talking to clinicians nationally about what best practice looked like and actually what they want from a product. Nothing to do with brand, but what do they actually want from that product line itself, you know? And they consistently gave me the same answers. But when I said to them, well, when you choosing your product for formulary, are you actually looking to see what the absorbency looked like? Do you know where to get that standard test data? Because there is quite a wide variation. And in the majority of cases, that wasn't so. So, you know, there are standards available to us to review when we're making these choices. Types of standards will be around the structural standards defining the product's structure and composition, so the formulation of that product. The performance standard characterised by one or more functions of the product, which might be absorbency, it might be absorbency under compression, it might be adhesion, and so on. There's quite a long list of functions. And safety standards as well to ensure that they're appropriately used and not likely to adversely affect patients' health. The first standards, you'll probably be surprised to hear, were published in 1911, so a long time ago. So we were already developing a range of products at that time. In 1922, there were over 80 products described in the standards, and these largely consisted of cotton fibre. And by the 1980s, EU legislation led to dressing classification as medical devices, which added a little bit more complexity there. Those performance-based standards, so in the 1990s, this saw changes to the rigid test standards by the Surgical Dressing Manufacturers Association, because they were seen to be preventing market access to products that were more innovative. So the Surgical Materials Testing Laboratory here in the UK in Wales, they pioneered some standard test methods for bandages and alginates, films, hydrocolloids, and hydrogels. And many of these standards were then adopted as wider EU standards. Some of those things looked at, you know, absorbency, permeability, antimicrobial activity, bacterial barrier as well. And you'll see many of these things mentioned in the marketing literature for products. But I just wonder whether you realise that you can actually look at this data for yourself and you can compare products using this standard test data. Many now are incorporated into framework requirements for clinical specifications. So some of the work that I did with the NHS supply chain, who provide 80% of product lines into acute services in the National Health Service, we actually further developed clinical specification around wound care product lines, incorporating standard test data. So that is available to you through that route as well. So I'll just run through very briefly some common products that you might use and the things that you might think about, things that clinicians told me that they considered were important. So gelling fibres, they're widely used product line and increasing in popularity, also known as hydrofibre. That's a trademark, and as a hydrocolloid fibrous dressing. It's a synthetic fibrous dressing for moderate to high exudating wounds. The fibres absorb and turn to gel, as you know, so they don't adhere to the wound bed, apparently encourages autolytic debridement at the wound interface, and there is some evidence to support that. And of course, they encourage moist wound healing, keep the wound bed moist and promote granulation tissue. So you can see they're very, very widely used in wound care. And the important characteristics of these products that people said that were important to them was that the wear time. So always look at your wear time. What's this indicated? And what I've seen developing over recent years is that is a longer wear time for products, and some of these products will now have a wear time up to 14 days because they specifically need to be used in some types of wounds like burns for longer periods of time. It doesn't mean to say you have to leave them in place for that amount of time, but it's an option. But you should always look at that in the indications for use in your product if you do intend to leave the dressing on for that long. But it's really important that you understand these things when you're choosing products for formulary. The absorbent capacity as well. So in ribbon, the variation there is between 13.1 and 25.9 grams per centimetre. So you can see already really wide variation. So if you're telling me you want a product that is very absorbent, then you need to be checking the standards to make sure that that's what you're actually choosing. And again, the absorbency capacity for a sheet there's a wide variation there between product brands. And lots of people said that it's important that these products don't break when they're removed from a wound. And so the rope breaking when wet under maximum load, and this is a standard test as well. Again, there's a very wide variation there in that product line, so something to think about. Super absorbent dressings as well. There's a huge growth in this market. I would say more recently introduced into wound care. Much more recently than foam dressings, and seen, I think, by some as an option, particularly if we want to maintain the dressing for longer. Majority are non-adhesive, although there are some with adhesive borders. We more recently have products with silicone in actually as a wound contact layer as integral to the product. And of course, those are the things you need to be considering now as well if you're introducing these into your formulas, super absorbent, that there is a range of these products available now. You need to be very specific about what you need to use these for. Some contain cellulose and some contain super absorbent polymers, so you need to be sure kind of what you want in that product, how you want it to absorb. Do you want it to wick laterally? Do you want it to wick vertically? All these things can be quite different. So intended use, so they're an enhanced fluid handling capacity, but do we know what that is? Do we know what that is under compression as well? Because we very often apply these products to patients, particularly lower limbs, and then some practitioners will apply compression over them, or they'll certainly apply a bandage. So we need to know, will they still absorb if we do that? Constituent parts as well, these can be different by product line, so we need to understand the specifics around that, and that will give us some clue about how effectively they're going to absorb fluid, because that's why we're applying the product, to absorb the fluid. So do we really understand how that's happening? If you just bear with me a second. Okay, so the clinical criteria here for choosing these dressings, this is what clinicians tell us, it's about the comfort of the dressing. So when that product absorbs fluid, how well will it conform to a limb or to the part of the body that we're applying it to? And this can be different by product as well. The absorbency ranged in these products, grams per centimetre square, from 1.34 to 2.57, so there was a difference in absorbency here. Absorbency under compression ranged from 0.6 to 1.28. So again, if we're going to be using the products under compression, important to look at that. And it's important. The other thing that was very important to clinicians was that the product maintained its integrity as well when saturated with fluid. And so you can imagine when you've got quite a heavy dressing to a lower limb, is the internal product, the absorbent core, going to remain intact? And lots of clinicians said to us, actually, that doesn't happen, and that the product moves down and can be quite uncomfortable and cause pressure to the leg, particularly if underneath a bandage. And we did ask SMTL if they would look at this for us, and they said there was no standard test data, but that is in development at the moment. So that's something that we will be informed about in future. And just something to think about here. I mean, I know, Leanne talked about a perfect storm here, and she said, actually, all these things are coming together, aren't they? And they're giving us lots and lots of problems. And we're seeing that sort of that chronicity of wounds increasing, and we're seeing that, the spend is increasing, and we're seeing the confusion and so on. I just want you to think about care pathways for a minute, and how we choose products and how we choose care and process for care for our patients. And there are lots of words here on the screen about what that pathway should be, you know, what the direction is. So, you know, they're tools to assist the cost-effective management of clinical outcomes. They provide direction in a stepwise fashion. Clinical pathways are tools to guide evidence base. They translate clinical practice recommendations into clinical process, and on and on and on. Nowhere in those descriptions does it say that this is a tool for choosing a brand of product. And what I increasingly see in practice, and there's been a real growth in this recently, is that we design the pathway for wound care around the product. So the highlight of that pathway is actually the brand of the product, and we build it around the brand. And that's something that we really, really must be moving away from. We must be moving more towards including a clinical requirement and clinical specification for the product in the pathway rather than the brand. And just getting back to that perfect storm as well, we also find ourselves in a very, very challenging time in terms of supply. So our product lines are constantly disappearing, even those that sit in with our national procurement provider, for a variety of reasons. So, you know, we've got further lockdowns going on in China, where a lot of our products are manufactured. Even the products that are manufactured in the UK, we have supply chain issues with the materials for those products. We have shipping issues. We have all kinds of challenges around sustainability now, and some products that we may not be able to use in the future because they are no longer sustainable options. So recently we lost our product supply for post-operative wounds in cardiac care, cardiac surgery, in one of the organisations that I work for. And we had real challenges with the clinicians moving away from their branded product because the pathway said this is what we have to use in this care incident. And actually it had bore no relationship to the outcome of the wound or the, or the whole service there, but it was a real challenge. So I think we really need to be moving away from that mindset.
Sian, can I ask you perhaps if you could bring us to a close, please? Because I'm conscious of the time.
I'm about to do that now. So what are our priorities then? So just to sum up, really, you know, as Leanne talked about earlier, there's a wide variation in practice there, and it's influenced by many, many things, but product selection is one of those. So we really need to be thinking about the way that we are choosing our products, and what do we want in our products, the key deliverables, the clinical specifications and requirements, and really, really be mindful of the availability of the standard test data in those choices. Thank you.
Sian, thank you. I'm sorry to hurry you at the end. Now, it's with a certain amount of trepidation and fingers crossed that I'm going to try again with Katie. I hope you're there. Katie Leake, she's the lead tissue viability and lead on tissue viability and continence at the University Hospitals at North Midlands. Katie, hopefully, fingers crossed, over to you.
Can you hear me?
We can. Wow,
wonderful. That's a great start.
What a relief.
Thank
if you
you,
could
Roy.
just keep an eye on the time, please, because we've got a huge number of questions and I want to do justice to them. Thank you.
Okay. I'll just wait for my slides to come up.
There we go.
Brilliant. Thank you. Good afternoon. Just want to start by saying this is my first webinar, so please bear with me and we'll get started. I'm going to do an overview into the behaviours and the practice within an acute setting. So currently within particularly my trust, I feel that there is a reduced autonomy at ward level. Staff are heavily reliant on tissue viability service to review all types of wounds, including rashes sometimes, and things that don't really fall under tissue viability specifically. The stock levels on the wards and the dressing selection is very poor. Sometimes you'll go into wards and you'll have a few film dressings, maybe the odd bandage, and you're having to run around and try and collect all your equipment before you can actually go and do a dressing. And that makes things quite difficult. There's increased time pressures on the wards, and by the stock being kept in different locations, when you're trying to set up a trolley, it can be quite complex and time consuming to try and deliver that care. There's lack of awareness about the modality of dressings, and the documentation is extremely poor around dressing changes and wound assessment. So I went onto the wards and did a bit of a data capture to just get a feel for what staff know about and what their perception is in regards to tissue viability and dressings particularly. And what was identified was basically a lot of staff will choose a silicone foam dressing as first line for superficial wounds. If it's not a silicone foam, then they tend to go for a post-op. Most of the staff, so just over 50% of the staff, refer most wounds to tissue viability rather than trying to manage that wound themselves. And that's down to lack of knowledge or anxieties around choosing the correct dressing for that wound. A lot of staff would like to know more about modalities of dressings so that they can manage non-complex wounds. And then I threw this in there, which I found quite interesting. I asked staff which dressing was a hydrocolloid. And as you can see, the results indicate that the majority knew, but there's quite a lot that didn't. And hydrocolloids came around back in the 1960s. This is one of the oldest dressings that came onto the market, but yet our staff are not aware of what a hydrocolloid is. I then went on to look at tissue viability referrals. So within the referral system for April, we had 493 referrals. I broke that down into categories. Effectively, the pie chart within the slide shows that over half of that wounds didn't really need specialist input and could have been managed in a different way. I then went on to look at incident reports, so datexes that were submitted to the service, and how many were picked up and not required to have any input from tissue viability and could have, again, been managed at ward level. It was 31 out of the whole month, and that equated to 1 whole-time equivalence week's work, which is quite substantial. So what should a tissue viability service manage? Should we be managing complex wounds like the ones in the pictures? Should we be offering a holistic assessment of these wounds and trying to get them to heal, as Leanne mentioned earlier? We should be focusing more around prevention, so pressure ulcer prevention, prevention of SSIs and SWD. But instead, the reality is we're getting referrals for these types of wounds. So some of the issues around the referrals that we get is that a lot of staff don't understand what to do with a wound. They struggle with categorisation, and we can only take what is written on the referral as truths. So we end up going to see the patient because we think we're going to see a category 3. In actual fact, we end up seeing a scab on a knee. So I went round and had a little look at storage as well, which is a common problem. As you can see, these are current issues that we have with storage. There's overlappings of dressings, they're all mixed on one drawer. I quite like the sample that we've got in the middle there, where we've got a biotin alginate box with a Comfeel in it.
Okay, I'm back. That's cool.
A lot of the problem with that is that we've got the same brand of dressing. So they look the same, they're the same colours, they're in the same box, but it's a different category of dressing. And that is actually one that was on one of the wards there. So does this make choosing a dressing quite complex, having them all mixed up like this? Documentation. I don't know if this is just my area, hopefully not. But this is what our documentation looks like currently. So we get for multiple days, up to sometimes 2 weeks, dressing intact, dressing intact, dressing intact. But I can never pinpoint when that dressing was changed, what that wound looked like. Was it deteriorating? Was it improving? It's very difficult to pinpoint that. And I think that's very important. Over the years, we have amended the documentation to try and simplify it, to improve compliance, and still we get this problem. So how can we make things easier? There was a study by Kabayahai, hopefully I've said that right, where he looked into human factors engineering, and he looked into colour coding, specifically within folders that were used in ED. By just changing the colour of specific folders, it improves the compliance of healthcare staff, which then, in turn, improved patient care. So we devised a selection chart, and it's quite simple. The colours obviously indicate a type of dressing, so pink would be hydrocolloid, and then the trolley will have a pink drawer with hydrocolloid dressings within it. So if staff had something like this on the wards, would it give them a little bit more autonomy to be able to select the correct dressing as soon as the patient hits the wards, rather than waiting for sometimes up to a week in busy times for a tissue viability nurse to come and tell them what dressing to use? We know that they'll be using the correct dressing. Because currently, with some cavity wounds, we'll go and see them and they're covered. They're just covered with a silicone foam or a absorbent pad and film, but they're not actually managed correctly until we go and intervene. So should we be giving the staff a little bit more autonomy? Following the colour guide, will that allow them to learn a little bit more about the type of dressing rather than the brand of dressing? So they'll be able to refer to a dressing as a hydrocolloid or a gelling fibre rather than Aquacel or Comfeel. So this is something that we're hoping to evaluate within the wards. I will hurry up there because I know that we've not got long for questions. So thank you very much.
That's terrific, Katie. Thank you so much for that. I think we're all now, are we all back together again? If you could all turn your videos and sound on for me, please. Thank you. Sean, there you are. Good, perfect. Thank you very much. Okay, there are a huge number of questions and some of them overlap. So if you'll forgive me, I'm going to try and do in the good old trade union style of trying to produce composite questions, and I hope that everyone will feel they've had justice. I think, I mean, the general sense that I get from these three excellent presentations is one of utter confusion. I mean, we normally look to the National Institute for Health and Clinical Excellence, don't we, for nice guidance to see us through this. And I think it was Sean who was telling us about, you know, lots of other people are producing guidance and what have you. I mean, if I went to you first, Leanne, what role does NICE play in all this?
They play an absolute pivotal role. I'm a vascular nurse consultant, so I follow the NICE peripheral arterial disease guidelines of how to manage peripheral arterial disease. It tells me when I need to image them, when I need to intervene on them, what type of imaging I should use, what type of intervention I should use, and what type of medication I should use. It also clearly tells me when I should not use that type of approach and how I should identify lifestyle, health behaviours, and what medication I should use. It becomes very clear standardisation based on evidence base of how to manage a patient. There is no NICE guidelines for the management of lower leg wounds within the UK. Isn't there?
I thought there's some guidance that were published in 2015.
From NICE?
Yes.
In relation to?
Well, I've got a copy of it here. I'd try and find it for you. Maybe I've got the wrong
NICE published lots of recommendations about the management and prevention of pressure ulceration.
Yes, pressure ulcers, quality standards, 11th of June 2015. Indeed. Does that play a part in any of the thinking?
Absolutely, because that should be the Bible, if you like, that we all read, or the Quran that we all read. That should provide the standardisation of what we do. And NICE has done that with pressure ulcers, and that's been fed down through programs like React to Red, and we have made improvement. But in terms of the management of lower limb wounds, which is my passion, there is no such thing. There isn't that high level of guidance. The best we've got is the National Wound Care Strategy, and hallelujah for that, because it actually provides a degree of standardisation. But what we need is actually, we need that to be reflected in the NICE documentation. Because as a health organisation...
Can I just got an eye on the time? So forgive me if I cut you short. I'm not being rude. It's just I want to give everybody the opportunity to contribute. I mean, Sean, in terms of procurement, why do you think it is that NICE haven't produced guidance on this hugely important topic?
Around products, you mean, or around lower limb?
Well, around any of this, it just seems to me that any manufacturer can come in with any product. I mean, before COVID, I used to go to Medica every year, which is the big festival in Dusseldorf about kit and caboodle and all the rest of it that there is around healthcare, and the wound care hall is one of the biggest. There are a huge number of people getting into this market, and it just seems to me that we would all benefit from so much sort of tighter focus on what works.
Well, to answer your question, there is some movement there. I don't know whether there's any appetite from NICE to look at this. I know NICE have produced some evidence reviews of some product lines that they felt to be innovative. I'm not sure whether that helped in the marketing of those products or not. NHS Supply Chain, who are the national procurement provider, have taken some steps towards talking to clinicians about clinical specifications and actually putting those into their requirements for their frameworks for wound care products. So ensuring that the right products are provided. I did see somebody's commented in the chat about the lack of availability of some of those products, because that is seen to have been some rationalisation there to save some of the public purse. And I would say that's related to global shortages of product. That's not just related to NHS Supply Chain. You'll find that suppliers may have some small stocks of those products in their own warehouses, but if we were all to use them, they would soon disappear. It's a much wider picture than that. It's not just about wound care, it's about all clinical products that we're using at the moment, and we are in a very, very challenging situation. But also, just moving on from that, the National Wound Care Strategy is also starting to look at safe choice of products. They don't particularly get involved in providing any direction in terms of brands or products or so on. But there is some appetite to bring together, NHS Supply Chain and, the BNF and prescriptions and so on, so that we understand what the specifications of those products look like, so we can make better choices.
Okay, thank you. I just want to let everyone know that because of the interest in this and the number of questions, I've been given permission from the voice of God that I can overrun to 2:10. So I hope that's okay for everybody, and I'll do that. I think Una Adderley makes a point in the questions. The NWCSP has persuaded NICE to work with SIGN to update, SIGN is the Scottish equivalent of NICE, to update and possibly extend the leg ulcer guidelines. There are also a number of NICE outputs on very specific products. But what is needed is proper NICE evaluation of groups of products for specific clinical applications. I thought, Katie, it was interesting because you were talking about autonomy, the autonomy of clinicians to work on the ward. And I wondered is autonomy a way out of this confusion, or is it just a way into more confusion?
Well, I think that staff on the ward obviously have to be a master of all and an expert of none, if you like. So they do rely on specialist nurses, a variety of specialist nurses, to give that advice and that support. Whereas I know when I qualified, some of those decisions I had to make myself around simple decisions, and all the complex decisions would then be, advice would then be sought from the specialist clinicians. Now, I think, and as well during the pandemic, staff have they're very deflated, they're exhausted, and they now rely more so on the specialist services to tell them what to do.
Yeah. I got an interesting question here from Alison Hopkins. She said, "This is frustrating. Talking about heavy pads should not be an issue if compression was used. Are we fiddling?" We are, she says. We're fiddling whilst Rome burns comes to mind. Is that fair, Leanne? I see you smiling.
Completely agree, and this is where that lack of standardized approach is where we need to be coming from. Talking so much about the product is like putting the cart before the horse. Let's get the fundamentals of care right: timely assessment, accurate diagnosis, and evidence-based strategies. Strong compression for venous leg ulcers, offloading for patients with diabetes, revascularization for arterial wounds. That's the starting point. Just what dressing you put on is just flowery rubbish that can sit on top of that. We need to get all of that right, and then it's time we talked about products. But actually, the bigger gains of this is the bigger picture, if you like. I just think it's important to call out as well. It's not just nurses that's dealing with wounds. There's many other healthcare professionals that are involved in the management of patients with wounds these days. Podiatrists, physiotherapists, we've got vascular nurses who are podiatry background. We've got lymphedema nurse specialists who come from a physiotherapy background. So we've got a whole variety of people involved at this. But I do think, in a way, we have to take some responsibility. I think we have overcomplicated this. I think we've made things more difficult to people to understand. And I love bringing it back to the simplicity of here's a 4 coloured drawers and you use that drawer for that wound, that drawer for that wound. That's bringing it back to the simplicity. You get away from the product, you think about the big picture.
Yes, and that's what nurses are good at, aren't they? They really are. I saw that and thought, wow, somebody needs to patent that, and then there'll be another product we can buy. Andy Brown was saying that our procurement, his procurement department, wherever he is, Andy, wherever you are, thank you. Our procurement department are experiencing weekly issues with products being delisted, and we're raising concerns with formal complaints to NHSSC. I hope it helps.
I'm not sure whether it will help or not, because I think we don't have control over the global logistical crisis that's going on at the moment. So I would say by all means do that, and I'm doing that myself, obviously, for the organisations that I work for, but I'm not sure that it's going to help us out of this predicament at the moment.
Well, it's a bit like Tesco's, I suppose. Every little helps, isn't it?
Yeah. It does help focus.
Sorry to interrupt you. I've just been asked to tell you that we've had a bit of a technical issue with the Q&A, but so what we're going to do is we're going to send all the questions afterwards to the speakers and ask them just to give us some answers, and then we will send the full document to everybody who's registered, so you won't miss out on the questions. But in the meantime, we've got a little bit of time left. I was interested. There were a number of questions about data, and I forget which one of you said that we're kind of drowning in a sea of data, which is always the case. We've got loads of data and no information. Where do we see this going? Because there are lots of products that capture data on certainly leg ulcers, because I'm well aware of it. Somebody's got their phone on. What can we do about data? Because I suspect that after COVID, we've kind of moved into the data era of the NHS. We're much more aware of it.
I think the data stuff is probably the hardest to solve, but I think is the shining beacon that I can see coming over. I think changing the nursing culture is a very difficult task. In the National Wound Care Strategy Programme, I've got a full data arm, and they are helping us to release that data. Not change dramatically of more data collection, but actually using the systems that we've got, the information that we put in, but actually getting us meaningful information out the back end. And the one thing that the National Wound Care Strategy Data Arm is trying to do is to at least level it up, that we're all collecting the same data. So at least then we can start to talk about things in the same language, to provide hotspots across the UK of good practice and where areas need to be improving. So I think that it's the hardest nut, but I do see it happening now. I do see the glimmers of the armoury coming over.
Yeah,
And
I think you're right. I think there's a willingness now to get into the data piece more now after COVID. Katie, do you? I mean, in your practice, do you capture any data? Do you look at recovery times, wound shrinkage, that kind of thing? Do you capture any of that data? Is it useful for you?
So we capture the majority of data that most other trusts do. So in terms of MASD and pressure ulcers, SSI data has, the surveillance has come to a halt over the last 2 years. No surveillance has taken place from IP due to the pressures they've been under with COVID. But hopefully going forward, they're going to start picking up on that surveillance, and we'll get some relevant data that we can make some changes with. Other than that,
But this is where we need the innovation for my nurses to currently do a wound assessment and enter it onto System 1, which is the templates that we use. It takes them 45 minutes on a computer to enter the data. You know, we have digital solutions already available, like apps on a phone where you radio button click and you can cut down your assessment entry time by about 70%. That's what we need to be looking at. And the National Wound Care Strategy are looking at a number of these approved apps, if you like, that can integrate with the systems that the NHS already uses. It's that type of innovation that we need, because actually we need to find some time to release back to care, to do the assessments right, to use the evidence-based practice.
Yeah. Sean, from the procurement point of view, does that feature in your thinking about procurement of product, the digital piece, the radial buttons that map? I mean, I saw that, must have been 3 years before COVID, in a leg ulcer clinic I went to. I think in Basingstoke there was one. I mean, is that going to happen? Is it happening? Are you doing that?
The problem with the NHS is, and I know Anne Jacqueline's on the call and she's probably laughing now, is that we none of our systems talk to each other. So actually, from a national perspective, and I don't work with the national procurement teams anymore, but from a national perspective, that would be quite difficult. And I know that, you know, and Andy's sort of said this already, there's lots of frustration around how we communicate with those teams as well directly. So all I can say is there's lots of work going on in the background. If we could pull together the NHS on one system, that would be marvellous. I don't think that's ever going to happen. I think we're all going to develop our own internal systems. We have lots of product selection options in terms of vending and so on that goes on within organisations at the moment. We have vending for drugs, vending for various products internally within organisations that can be controlled by apps and so on.
Can I just ask you, where is this data kept? Is it kept in the GP surgery? Is it on EMIS System 1? Is it Rio? Is it community-based? I mean, where is the data kept?
It could also just be in paper notes still, believe it or not, even in today's world.
I find that very hard to imagine. Look, we got 3 minutes left, so I'm going to give you all 50 seconds. That's only so I can do a sign-off at the end. If you could change one thing, what would it be? Now, the simple questions are always the toughest questions, so I'm vamping a bit here to give you a chance to give me an answer. But I think perhaps why don't we start with Katie? If you know, as a practitioner, as the inventor of Sisters Red and Yellow drawers, who I could have put that better, couldn't I? If you could change one thing, what would you change?
I think I'd like to see staff using their own initiative. I'd like to see them managing wounds better and having an understanding about basic selection of dressings.
Yes, and that comes from when you was in your presentation talk about autonomy. You see the future of that as the autonomy piece.
Yeah, and that will allow specialist services to pick up things like continuation of compression therapy within acute trusts, because we don't do that. Patients come in with compression, it's taken off until they go home.
I think that's really interesting. You know, at the time that I've run hospitals and things like that, if you leave it to the nurses, things do get sorted out. Sean, another nurse, you could change one thing, what would it be?
I think for me, from kind of my journey over the last 5 or 6 years, I'd say I'd like to see some relevant national guidelines around how people in those positions choose product for their formulary, so that we have some transparency there, and we're also able to demonstrate, so it can be, you know, transparent and demonstrate
the transparency
how we make those choices.
And sorry, I've cut off you. There's a slight delay on the line. And Leanne, you've got 15 seconds, I'm afraid.
Very, very easy of mine. What I'd love to change is access to evidence-based care for every single patient. I'd also like to change the culture. Expect wounds to heal. If they don't heal, escalate it. If you had a patient with a chest infection that wasn't getting any better, you would escalate it. We need to be thinking about the same with a wound.
Yeah,
if it's not improving, escalate.
Yeah, I absolutely get that. And if you're a patient or a relative, ask, why isn't my wound getting any better? Look, can I just say thank you all? And in the chat, when some of my chats re-emerged now, somebody said, whoever it was, thank you for being so frank. And I think it has been a really frank, you know, sleeves rolled up, no holds barred exchange about dealing with clearly something that just sort of battles that battles the whole of the healthcare system. I'm hesitating slightly because I'm having to work with the text now because of my problems this end. So we're saying that we're pushing, we're continuing the conversation with Una Adley and addressing the strategy. She's speaking at the Royal Society of Medicine on the 22nd of June at ISPSC, and the fact that we will be continuing the conversation with Una and addressing the strategy. It's a repeat message, sorry. And as I say, she's speaking at the Royal Society of Medicine on the 22nd of June. So that's a date for your diary. We'll pick this up again. I hope you've enjoyed our exchanges. These are one of these topics, isn't it? That an hour just isn't enough. And we've had some real experts with some great answers. So can I thank Fala for facilitating this, enabling it, making it happen. They're manufacturers, they're in this space, but they're very frank about their role. They just want to make life easier for nurses, and that's no bad thing because that makes life easier for patients. So thank you all very much. Thanks, Leanne, Katie, Sean, and to our organisers, Government Connect. My name's Roy Lilly, and I look forward to seeing you somewhere in the hinterland of the NHS real soon. Thank you all very much. Bye-bye now.